Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Now that we know how to treat, let's talk about how to monitor patients on resmetirom. Every promising drug brings with it responsibilities. In this session, we shall focus on how to initiate, monitor, and adjust resmetirom therapy, paying special attention to potential side effects, lab markers, and cardiovascular safety. I shall share practical tips on follow-up protocols and red flags that every practicing physician should keep in mind. The drug acts via thyroid hormone receptor beta, enhancing hepatic fat metabolism, but it can slightly reduce LDL and mildly affect thyroid excess markers. Before initiation, assess lipid profiles, TSH, liver enzymes, and fibrosis markers. Recheck these at 12 weeks and then every 3 to 6 months. Watch for side effects like mild diarrhea, nausea, or rare elevation of liver enzymes. Importantly, cardiovascular safety has been favorable so far, even in high-risk groups. With structured monitoring, resmetirom can be a safe and effective long-term therapy. Bismillah ar-Rahman ar-Rahim. Resmetirom clinical concerns. We start from the indications. Resmetirom is indicated in conjunction with diet and exercise for treatment of adults with metabolic dysfunction associated steatohepatitis with moderate to advanced liver fibrosis consistent with stages F2 to F3 fibrosis. It means if your patient has got no fibrosis or F1 fibrosis, he or she should not be started on resmetirom. Similarly, if your patient has got F4 fibrosis or cirrhosis, again, he or she should not be started on resmetirom. Second important point, resmetirom is not the alone therapy. You must advise dietary restrictions and exercise in addition to resmetirom, and then you will get the positive impact or effects of resmetirom. What's the mechanism of action of resmetirom? Thyroxine hormone replacement beta activity is vital for the hepatic lipid metabolism. We know that. We have already discussed that THR beta are highly expressed in liver and involved in regulating lipid metabolism and inflammation in the liver. THR beta regulate mitochondrial breakdown of liver fat. Patients with MASH have reduced level of THR beta receptor activity in the liver. By selectively activating THR beta, resmetirom modulates genes responsible for lipid metabolism, increases hepatic fat metabolism, and reduces lipotoxicity, thus leading to reduced hepatic fat accumulation and inflammation. This beta selectivity also protects against the systemic adverse effects of excess thyroid hormone activity, which are mainly mediated by thyroid hormone receptor alpha. What are the pharmacological concerns? Absorption. Peak plasma time is 4 hours. Peak plasma concentration of 80 milligram is 778 nanogram per ml, and that of 100 milligram resmetirom is 971 nanogram per ml. Area under curve for 80 milligram resmetirom is 850 nanogram per hour per ml, and for 100 milligram resmetirom it is 7780 nanogram per hour per ml. What about distribution of this drug in the body? It steady state, protein bound, more than 99% of the drug is protein bound. Metabolism, it is metabolized by cytochrome P2C8. The MGL3623 is a major metabolite with 28 times lower potency for THR beta than resmetirom. How it is eliminated from the body? Its clearance is 17.5 liter per hour. Half-life is that of 4.5 hours. It's excreted in feces 67%, and mostly the metabolites, these are excreted in the feces, and in the urine 24%. Dosage forms and strengths. It is available in tablet form in 60 milligram, in 80 milligram, and 100 milligram tablet. Dosage is based on actual body weight. Those weighing less than 100 kg, it's 80 milligram per oral per day. And for those whose weight is 100 kg or more, it's 100 milligram per oral per day. It's administered with or without food. And it should be stored at 20 to 25 degrees centigrade, and excursions permitted to 15 to 30 centigrade. What are the dosage modifications? When you start a patient on these drugs, does the patient needs dosage modifications? Yes, at some times. In case of hepatic impairment in child class A, no dosage adjustment is necessary. So for child class A, you can give the same dose. Moderate to severe, that is child class B or C, it may increase resmetirom plasma concentration and risk of resmetirom adverse reactions. And NASH cirrhosis safety and efficacy is not established yet for clinical use. Therefore, avoid using resmetirom in child class B or C cirrhosis. What about the renal impairment? In mild to moderate renal impairment, that is creatinine clearance 30 or more than 30, no dosage adjustment is necessary. And for severe renal impairment where creatinine clearance is less than 30, it is not studied, so don't use in such cases. What are the contraindications? In fact, there are no known contraindications except if there is any hypersensitivity. In pregnancy, there are no available data on resmetirom use in pregnant females to evaluate for a drug-associated risk of major birth defects, miscarriage, or other adverse maternal or fetal concerns. There are risks to the mother and fetus related to underlying maternal MASH with liver fibrosis, such as increased risks of gestational diabetes, hypertensive complications, preterm birth, and postpartum hemorrhage. We know that. In the animal data in pregnancy, adverse effects on embryo-fetal development occurred in pregnant rabbits treated with resmetirom at 3.5 times the maximum recommended dose during organogenesis. These effects were likely associated with maternal toxicity, whereas no embryo-fetal effects were observed at lower dose levels with better tolerance in pregnant rabbits. No embryo-fetal development effects occurred in pregnant rats treated with metabolite MGL3623. A pre- and postnatal development study in rats with maternal dosing of resmetirom during organogenesis through lactation showed a decrease in birth weight and increased incidence of stillbirths and mortality postnatal days of 1 to 4 at 37 times the maximum recommended dose. What about lactation? There is no information regarding the presence of resmetirom in human or animal milk, effects on the breast infant, or effects on milk population. What about pediatric use? Safety and effectiveness is not established, so it should not be used. What about geriatric use? No overall differences in effectiveness observed in patients more than 65 years of age compared to younger adult patients. Numerically higher rates of adverse events observed among older patients. What should be the cautions during resmetirom treatment? Hepatotoxicity has been observed. Monitor patient during treatment for elevated liver function tests and for developing liver-related adverse reactions. Monitor for symptoms and signs of hepatotoxicity, that is fatigue, nausea, vomiting, right upper quadrant pain, or tenderness, jaundice, fever, rash, and or eosinophilia more than 5%. If hepatotoxicity is suspected, discontinue therapy and continue to monitor. If LFTs return to baseline, weigh potential risks against the benefits of restarting. If LFTs do not return to baseline, consider drug-induced autoimmune like hepatitis or autoimmune liver disease in evaluation of elevations in liver tests. The gallbladder-related adverse reactions, cholelithiasis, acute cholecystitis, and obstructive pancreatitis gallstones were observed. If cholelithiasis is suspected, gallbladder diagnostic studies and appropriate clinical follow-ups are indicated. If an acute gallbladder event is suspected, interrupt treatment until event is resolved. Instruct patients to immediately report any signs or symptoms of severe liver injury, for example, fatigue, nausea, vomiting, right upper quadrant pain or tenderness, jaundice, fever, rash, or symptoms of gallbladder adverse reactions, including cholelithiasis, cholecystitis, and obstructive pancreatitis gallstones to healthcare provider when they are using resmetirom. What about drug-drug interactions? It's a very important topic. When you prescribe resmetirom to your patients, you should be aware of this. Just a few words about the P450 enzyme. The P450 enzyme family has two main members, CYP3A4 and CYP2C8. Both are involved in drug metabolism, but they differ in several important ways. And what are those differences? They are in the abundance and role of these two family members, then substrate specificity. Inducers and inhibitors are different for both, as well as clinical relevance is different of these two. Let's see these differences in some detail. First, abundance and role. CYP3A4 is the most abundant cytochrome P enzyme in the liver and intestines. It is involved in the metabolism of more than 50% of all marketed drugs. It plays a major role in first-pass metabolism. As compared to CYP3A4, CYP2C8, it's less abundant than CYP3A4. It metabolizes a smaller set of drugs, but still clinically significant. The second difference is substrate specificity. CYP3A4 substrates, these are statins, simvastatin, atorvastatin, macrolide antibiotics, benzodiazepines, calcium channel blockers, and immunosuppressants, that is cyclosporine. While CYP2C8 substrates are pioglitazone, rosiglitazone, paclitaxel, anti-cancer drugs, repaglinide, antidiabetic, imodiaquine, that is the anti-malarial. The third aspect is inducers and inhibitors. For CYP3A4, inhibitors are ketoconazoles, grapefruit juice, and clarithromycin, while inducers of this is rifampicin, carbamazepine, and phenytoin. Similarly, inhibitors of CYP2C8 are gemfibrozil and trimethoprim, while inducers are rifampicin and phenobarbital. The fourth difference is clinical relevance of these two family members. CYP3A4, due to its broad involvement, it is the most clinically significant for drug-drug interactions, while CYP2C8 is important in specific cases, especially with drugs like glitazones or paclitaxel, where inhibitions can lead to toxicity. So this is the difference between these two enzymes of the cytochrome P450 family, primarily found in the liver intestines, involved in drug-drug interaction. The CYP3A4, most abundant and clinically important, metabolizes about 50% of drugs, and the metabolizers are statins, antidepressants, anticonvulsants, and immunosuppressants. While CYP2C8 is less abundant but important, it metabolizes specific drugs and metabolizes glitazone, paclitaxel, repaglinide, and imodiaquine. The discussion continues. The drug-drug interaction profile of resmetirom is primarily based on its metabolism and effects on liver enzymes and transporters. So we can discuss the drug-drug interactions of resmetirom by those caused by the metabolism by CYP3A4 and CYP2C8, and then mild inhibition of drug transporters, then effects on thyroid hormone pathways, and then interaction with warfarin or anticoagulants. First, we take the metabolism via CYP3A4 and CYP2C8. Resmetirom is metabolized by the cytochrome P450 3A4 enzyme. The inhibitors of CYP3A4 like ketoconazole, clarithromycin may increase resmetirom levels, potentially increasing side effects. The CYP3A4 inducers, that is the rifampin and carbamazepine, may reduce resmetirom's effectiveness by increasing its clearance. Then the CYP2C8 inhibitors, strong or moderate CYP2C8 inhibitors can increase resmetirom plasma concentration and risk of resmetirom adverse reactions. The strong CYP2C8 inhibitors like gemfibrozil, if the patient is using this drug, resmetirom is not recommended in such case. In moderate CYP2C8 inhibitors like clopidogrel, if a patient is using clopidogrel in less than 100 kg, reduce the resmetirom dose from 80 to 60 milligram. And in patients weighing more than 100 kg and they are using clopidogrel, reduce resmetirom dose from 100 milligram to 80 milligram. Then the drug-drug interactions of resmetirom because of mild inhibition of drug transporters. Resmetirom has a mild inhibitory effect on certain hepatic transporters, including OATP1B1 and OATP1B3. These are involved in hepatic uptake of many statins and other drugs. Cautions may be needed when using with atorvastatin, simvastatin, or rosuvastatin. If the patient is using these drugs and the patients with MASLD, they will be, and most of these patients will be using these drugs. So here, caution should be taken as increased statin levels may raise risk of myopathy. Similarly, BCRP may modestly affect levels of BCRP substance, that is rosuvastatin. So if a patient is using these drugs and you are giving resmetirom, so the care should be taken. Remember, the OATP means organic anion transporting polypeptide 1B1 and 1B3, and the BRCP means breast cancer resistance protein. The third drug-drug interaction group is because of the effect on thyroid hormone pathways. Though selective for thyroid hormone receptor beta, resmetirom can slightly lower TSH levels or alter thyroid hormone metabolism, so caution is advised when co-administered with levothyroxine or antithyroid medications. Monitor thyroid functions if these are used together. And the fourth category is because of interaction with warfarin or anticoagulants. There is no strong evidence of direct interaction, but any CYP3A4 related induction or inhibition would potentially alter levels of drugs like warfarin or directly oral anticoagulants. So INR monitoring is recommended when initiating or stopping resmetirom. So summary for clinicians: check for CYP3A4 modulators, review statins dose if co-prescribed, and monitor TSH lipid profile and INR if on anticoagulants. And this is the summary for the clinicians, that its metabolism via CYP3A4. Resmetirom is metabolized by this enzyme. So CYP3A4 inhibitors like ketoconazole, resmetirom levels are increased, side effects are more likely. In CYP3A4 inducers like rifampin, resmetirom effectiveness may decrease. So mild inhibition of drug transporters can inhibit OAPT1B1, 1B3, and BRP modulators. So caution when using this with atorvastatin, simvastatin, rosuvastatin, as the statin levels may increase myopathy risk. Then an effects on the thyroid hormone pathways in slightly lower TSH levels or alter thyroid hormone metabolism. So caution should be used, and interaction with warfarin and anticoagulants. So caution with warfarin and oral anticoagulants direct drugs. This is a very important slide. If a patient is using clopidogrel, so in patient weighing less than 100 kg, reduce resmetirom dose to 60 milligram, and in those weighing more than 100 kg, reduce resmetirom dose to 80 milligram. If a patient is using gemfibrozil, then resmetirom is not recommended. If a patient is using atorvastatin, limit daily atorvastatin dosage to 40 milligram. Don't exceed this dose. If a patient is using rosuvastatin, and many of these patients will be using such drug. So in case of rosuvastatin, limit daily rosuvastatin dosage to 20 milligram. And if a patient is using simvastatin, limit daily simvastatin dosage to 20 milligram. In case of parvastatin, limit daily parvastatin dose to 40 milligram. If a patient is using pioglitazone, monitor for pioglitazone related adverse reaction. And in case of warfarin, no clinically significant interaction observed. What are the adverse effects? This is, again, you should be clear about it. For those adverse effects which are more than 10%, these include diarrhea 23 to 33%. This is the most common adverse effects or side effects, especially in the early phases, weeks, then later on it vanishes. Nausea 15 to 18%. ALT rise more than 3 times in 11 to 13%. AST more than 3 times rise in 9 to 12%. And those side effects which are less than 10%, which are less common. These include pruritus 6 to 10%, vomiting 7 to 8%, constipation 5 to 8%, abdominal pain 5 to 7%, and dizziness 4%. AST more than 5 times rise is 1 to 4%, and total bilirubin more than 2 times rise is 1 to 3%. So these are the couple of side effects, and you should be aware of it. And the ALT more than 5 times, upper limit normal is in 2% only. So with this, I thank you for being with me in this very important vlog, where we try to understand different clinical aspects, clinical concerns when we will be prescribing resmetirom to our patients. This is very, very important that we should be using resmetirom in the proper dosage and in the proper patient and in the proper scenario. If a patient, once again I repeat, has got no fibrosis or F1 fibrosis, that is insignificant fibrosis, he or she is not a candidate for resmetirom. If a patient has got F2, F3 fibrosis, this is the patient who should be started on resmetirom. And if a patient has got cirrhosis, again, this drug, results of this drug in NASH-related cirrhosis is not available, so don't use in that. Another point, when you are using resmetirom, when you are prescribing resmetirom, do prescribe the dietary restrictions, do counseling regarding the diet, as well as encourage the patient on regular physical activity. So here I end. Inshallah, we shall be continuing our discussion, and we shall try to explore the other aspects of resmetirom therapy. I am giving more time to this drug for the reasons, and for the simple reasons that fatty liver disease is very common in our setup, and I want that we should be using this drug for in a proper way, in a rational way, rather than overusing it or underusing it. So see you in the next vlog. Till then, take care. Khuda Hafiz.